Paul Woods, I'm a veterinary medical oncologist here in our Comprehensive Veterinary Cancer Center, the Morgan Campbell Center for Animal Cancer, and I'm also a co-director of the ICCI. I met Dr. Gustafson when I was doing my fellowship at Colorado, and then talking to Dan in March. He was quite excited to be coming here when I was out at CSU. I have to apologize though, because I think Jeff and Michelle brought him here thinking we'd be going to see Toronto versus Winnipeg tonight in the Stanley Cup, but things didn't quite come together. Dan is a big hockey fan. His kid plays high school hockey, so you know he's awesome. So I'll give our introduction for Dan. He has his Bachelor of Science in Biology from Santa Clara University, PhD in Cell and Molecular Pharmacology and Physiology from the University of Nevada at Reno. Following that, he did a postdoctoral training in radiation biology and pharmacology at Colorado State University, CSU, and the University of Colorado Health Sciences Center. He's held positions at the Center for Environmental Toxicology and Technology at Colorado State and the University of Colorado School of Pharmacy. At the School of Pharmacy, I was just going to say he developed a pharmacology core laboratory at the University of Colorado Cancer Center, which is an NCI-designated comprehensive human cancer center. The lab served the investigators on preclinical and clinical pharmacology studies with an emphasis on pharmacokinetics and pharmacokinetic modeling. Fortunately, when they created the Animal Cancer Center at CSU, they were recruited and be able to get Dan back to CSU, where he is now, and he's a professor of clinical pharmacology. He's the Shipley University Chair of Comparative Oncology, and also Director of Basic Research at the CSU Flint Animal Cancer Center. Dan also serves as the co-leader for the Developmental Therapeutics Program and continues to serve as the Director of the Pharmacology Shared Resource for the University of Colorado Cancer Center, which works collaboratively with research and clinicians to design and implement studies to measure xenobiotics such as drugs, toxins, natural products in biological systems and matrices. Dan has authored or co-authored over 120 original peer-reviewed scientific articles and journals, primarily in the field of cancer, chemotherapy, and pharmacology. And the overall theme of his laboratory is cancer therapeutics and comparative oncology. His laboratory focuses on developing therapeutic treatment modalities for cancer with an emphasis on the pharmacology of agents and development of animal, pharmacokinetic, and mathematical model systems to better reflect the clinical progression and pathology of cancer. His current focuses are on precision approaches to cancer therapies and the role of autophagy plays in the sensitivity or resistance of tumors to anti-cancer drugs. Today, Dan is going to discuss pharmacologic considerations in response of tumors to drug therapy. Thank you, Dr. Gustafson.
Thank you, Dr. Woods. All right. First, I want to thank Jeff, Michelle, and Paul for the invite to come up here. This has been outstanding, and I want to say thank you to all the students that presented today. I thought your talks were great. It's been very informative and fun, so you guys have done a great job. You keep me entertained. I didn't fall asleep once, as you can see in the front row. So what I do could have been talked about a lot easier just by saying the two words that I outlined in dark in my talk, drug response. And that's really what we're going to talk about today, is think about drug response and what makes up a drug response. And I'll show a model that I like to use of dose exposure in response as opposed to just dose response. And I love to see the fact that we're talking about dose response with oncolytic viruses, because that is something that historically people have just said more is better, and that may not be true, or give it all at once. So those types of considerations in terms of optimization of therapy can have huge effects on outcomes, and they're generally underappreciated because people think, oh, it didn't work. Well, maybe it did, but you killed the critter with it, so it didn't. So anyway, we're going to start off with some common assumptions of drug therapy that may or may not be true. And one is that dose is related to drug exposure. Okay, and this graph here, this is rapamycin in dogs at a series of dose levels. And if you look at area under the curve, in general, this is true. This is a significant trend, and in this case, you give more, you get more. Okay, so that's generally true. Drug exposure is related to response. So the more drug you get exposed to here by measuring area under the curve, the greater effect you have here. Here, this is response to vinblastine in terms of decrease in absolute neutrophil count. The more drug, the more neutropenia you get. Okay, again, generally true. And another one is that blood, serum, or plasma, whatever you want to pull out of the critter to measure, are a good indicator of drug exposure. So we measure in blood because we can get it, and we generally say that's a good measure of exposure at our target. Okay? So these are things I'm gonna talk about in the first part of my talk with regards to thinking about these kind of assumptions and paradigms and whether they are or aren't true, and how you can take them into consideration for study to make better decisions with regards to this paradigm, which is that dose and exposure are related by pharmacokinetics, and exposure and response are related by pharmacodynamics. And dose response is really a culmination of the PK and PD effects of a drug. So the more you give a dose, pharmacokinetics dictates how much exposure you get at the target where the drug's going to work. And then when you have the drug at the target, how the pharmacodynamic response to that exposure and whatever response you're looking at, and for chemotherapy it's generally both side effects and therapeutic response, how those are related to this exposure response relationship between whatever target you're looking at. And exposure can be easily assessed by measuring drug levels in the plasma, serum, blah, blah, blah. And this is really simple, okay? And so the ideal is you lean back and you go, yep, you know, it's easy peasy. No little PK, no little PD, measure stuff in the blood, you predict stuff, dose is optimized, lickety-split, okay? So that's generally how I think about, I go, yeah, this is no problem. Well, the reality is this, okay? That you get the windup, you throw the pitch, you're all determined, you're gonna do some PK data and good things are gonna happen, and the reality is that you get that look on your face as you get your data and you realize, that our dose and exposure can be nonlinear or highly variable when we have a problem. Exposure and response is inconsistent across my samples, and blood levels don't really correlate to our target drug levels. So we have to figure out other ways to do it. And I'm going to talk to you in the first part of my talk, when I really talk about drug and exposure assessments that we've been working on, how we try to take these into account. So you go sit in your office and you say, good grief, and you cry a little bit, and then go home. Okay, so it was good. The earlier talks today talked a lot about variability. And that's, if we can predict variability, that's where we can start doing personalized type medicine. And variability happens both on the PK side and on the PD side. And so the way I like to think about what my laboratory does is we study pharmacokinetics, and we may take into account genetics and size and environment and physiology and try to figure out where the variability comes from. And we'll do some modeling, and we do a lot of physiologically based pharmacokinetic modeling, which I'll show you. Those of you that know me or have seen my talks in the past know I'll talk a lot about this stuff with certain drugs. To give us an idea of drug in the body, then we like to think about how this blood and target levels correlate, and then how we get a response. And the second half of my talk is really going to talk about exposure and response and how we can predict that for tumors. And the sweet spot is this little bitty place right there in the middle. When we can get them both, then we can start making really good predictions about dose response. Once we understand the PK part of it, and once we understand the PD part about it, then we can really start thinking about giving the drug at a certain dose and getting an effect that we want. So, and I made this small on purpose because this rarely happens where you have a great idea of what's going on. Okay, so when I tell you that blood and target tissue are sometimes related. I'll give this example here, and this is some data that came out of my lab for both of these drugs. This is AZD6244, or as it's known now, selumetinib, which is a MEK inhibitor. And you can see when we looked at plasma levels and tumor levels in mouse models over various doses and dosing schema, you got a pretty nice correlation between tumor levels and plasma levels within the individuals. And so in that case, measuring it in the drug or measuring it in the plasma would really tell you about the exposure you're going to get at the tumor. Okay, and these were relatively well perfused melanoma tumors. It's more than one separate type of melanoma tumor. There's a whole bunch of them here, so it's at least 3. So it's not perfusion differences, blah blah blah, are all accounted for. With gefitinib, so here's IRESA here. And we did this study in collaboration with Paul Bunn years and years and years ago. When we looked at tumors and plasma levels, we also saw a nice correlation. So in these cases, equating blood, plasma, serum, whatever you're measuring it in, with target or tumor drug levels worked. Okay? But the problem is that's not always true. And here's an example from a phase 1 clinical trial that we did in dogs with lymphoma that did in collaboration with Doug Tham. And when we were doing this with hydroxychloroquine, and so the idea was to use an autophagy inhibitor just to do kind of safety with doxorubicin in lymphoma. And we actually took lymph nodes and we measured HCQ concentration. And when you look at the blood and the tumor concentration, what you should see here is that you see this looks linear, but this is not, because there's really no relationship between this axis and this axis, because this goes up from 10,000 to 40,000, this goes from 100 to 100, okay? And this one's up here. So there's really no significant correlation. And so we were like, oh, cradola, okay? Because measuring HCQ in the blood was not giving us any indication of autophagy inhibition in the tumors, because when we also looked at effects on autophagy in these tumors, it correlated to this but not to this. So we had to figure out a way to predict this, okay? All right, so the next question you should ask is, why the heck do I care about hydroxychloroquine, okay? And the reason is because when you look at canine osteosarcoma cell lines or canine cell lines in general, there is at least half of them are sensitive to hydroxychloroquine in a way that's pharmacologically reasonable. And by that I mean we can get that much drug into a dog without hurting them. Okay? So this is what we refer to as autophagy sensitive. A lot of this has been done in human breast cancer in collaboration with studies that we've done with Andy Thorburn at CU Denver. And when you look at canine cell lines here, and these are all osteosarcomas with the exception of Bliley, which is a transitional cell carcinoma, and this cell line right here, what you see is that when you look at the comparison of cell proliferation inhibition by hydroxychloroquine to human cells, these canine tumor cells seem to be pretty sensitive. And in fact, MDA-MB231, which is a mammary triple-negative breast cancer, we know we can treat with hydroxychloroquine and prevent growth and metastasis. And it's right here, one of the most sensitive human cells, and a lot of our canine osteo cells are right there as well. So we have some evidence that at least canine osteo is sensitive to autophagy inhibition, or at least a subset of them. And they're all right here. 6 of the 10 we have in our cell line panel at CSU are actually more sensitive than the mean, and some of these about a log more sensitive. So you're talking a log, then you got a tenfold difference. So you're getting pretty sensitive with regards to, and it's down in the micromolar range at that point, low micromolar. Okay. And it not only does it prevent proliferation, but it also kills them. So here you're getting down to 1, 2, 3 logs. You can see that you're starting to actually kill these tumor cells. So autophagy inhibition, at least in some of these cell lines, and this is the most sensitive one, which is what I think the OS 2.4, are killed. And if you look here in the HMPOS, and this is an incucyte looking at, these are nuclear labeled tumor cells, you can see that when you get out to 72 hours, these things, it starts to go down from the number here. So you're actually killing them, okay? And you see the same thing in the Gracie cell line. Here are some higher concentrations, but here's the control growing. When you start treating them, you can see that you start getting some of them to regress. You can actually kill them. And this is some data that we haven't published yet, and it's preliminary. We're working on some CRISPR knockouts now. But if you knock down ATG5, which is an important gene in the autophagy signaling pathway, it actually conjugates with ATG12 in the process. If you knock that down, you see that these cells stop growing. Turns out that the ones that are growing don't have it knocked down. So when you start knocking out these genes by doing genetic knockdowns, you see that you can also start killing them and or blocking growth. So canine OSA cells are sensitive to autophagy. We're working on the absolute dependence, autophagy dependence of these. So we're really looking at this as a potential target. So we were interested in this drug and trying to figure out, when we gave it, if we're measuring it in the blood, how much is in the tumor, or what's driving this lack of correlation between tumor and blood. Okay, well, this is what hydroxychloroquine looks like. Okay, If you look at it, you'll find out that it's a diprotic base. It can be, this is the old Mac to Microsoft, we're going to screw up your ChemDraw thing. So there should be an arrow here, but you can see the structure. And there should be, where the circle is, there should be a plus charge. So you can see when this protonates here, it gets charged, and then it can also get protonated here, which can distribute to here and here, and you can also get a plus charge. So you can get a diprotic form of hydroxychloroquine. And it turns out that you guys all remember this, right? What equation, who remembers what equation this is? The Henderson-Hasselbalch equation. Who remembered that? Liars. Okay. pH equals PK plus a log of salt over acid, right? What this tells you is that any difference in pH related to PK is going to lead to a tenfold difference in the next charged form. Okay, so it's a log. It's going to be a tenfold difference. So as the pH goes down 1, if you go to 6, you got 10 times more of the charged form than you did at pH 7. Okay, and that's important because it turns out that these two forms right here of hydroxychloroquine can cross membranes. These two forms that are multiple charged can't. And that's basically based on Lipinski's rule that says one formal charge can solubilize, 20 carbons, blah, blah, blah. Once you get 2, all right, then you're going to be too water soluble. You're not going to be able to shed the water to get across membranes, so you get trapped in membranes. Okay? Why is that important? Well, because hydroxychloroquine collects in lysosomes, which are acidic vesicles, and that's how it blocks autophagy. Is it collects in lysosomes, which are highly acidic, you get a lot of it, and it screws up the process of fusing the lysosome with the autophagosome, which is involved with the finishing of autophagy. So if you add hydroxychloroquine, you alkalinate the lysosome, you muck up its function, it can't form with autophagosome, so you can't finish the autophagic process. Okay? It's the exact same way it kills parasites, actually. It actually blocks their ability to break down heme, so they accumulate heme, and they don't make this polyheme, which is less toxic. And so they die. So that's why it's an antiparasitic. And it's really based on these acidic vesicles. So what we did is we started trying to model hydroxychloroquine in critters, thinking about the pH of the extracellular fluid, the blood, the cytosol of different cells, the lysosomal fraction and pH of different cells, to say, all right, if we can do this in the normal, then we can start thinking about a tumor. And if a tumor has a different extracellular pH, or a different cytosolic pH, then we can start actually thinking about why drug levels in the tumor might be a lot different than what they are in the blood based on these physiochemical and physiological differences in that tumor, because it may or may not be less acidified based on oxygen and excretion of lactic acid and all the things that change pH in certain things. So we, and by we I mean graduate students, started developing a PK model to start looking at this subcellular distribution of this drug, to get to the fact that when we give a dose, the exposure is different. Now, if we can do this right, we can actually start looking at exposure, at least simulating the exposure in this subcellular organelle that's actually the target in terms of blocking this process. Okay? I kind of already went through all this, but chloroquine or hydroxychloroquine, they do the exact same thing. They accumulate in the lysosome and block this fusion. And like I said, it's the same thing with its antiparasitic activity in terms of mucking up this heme polymerization process that they need to survive. And so you can see here, when you treat with hydroxychloroquine, you go from just a few autophagosomes to now there's a whole bunch of them. Why? Because they accumulate because you can't finish the process. Okay? So when you treat with hydroxychloroquine, the cell can't finish its autodigestive processes to make the building blocks it needs to make to survive. And in those cells that are dependent on this autophagic process, they die. Okay? And we think that canine osteosarcoma cells are one of these, or at least a subset of them, are in this dependent group, and we can take advantage of that potentially to use HCQ. Okay. So to get to that dose exposure, pharmacokinetic assessment, we put together a PBPK model of HCQ. It actually binds to melanin, and one of my grad students found a lot of data in albino rats, and so we figured we could play around with that because it actually accumulates in the eye and it has some ocular toxicity. So we added an eye compartment. We added a heart because it does have some cardiac effects, skin because it sticks to melanin, so we need to get it in there. We lumped tissues based on blood flow like you do with these things that you didn't really need. It's orally dosed, so we had to add a gut lumen and absorption into the gut tissue and then eventually in the blood and into the liver. We had some metabolic parameters, we peed it out, we pooped it out, and we added all those things. And we started to put this together, okay, which is how you put these things together. Okay. And after, it only took, 7-8 months, we did, because you got to, all these things are you got to do metabolism and you got to figure out where it is and all these things. So lots of parameters for Keegan to get together. And we had 3 different dose levels. Why did we do this? Well, because the other thing that I really like to do is I like to know in my mouse model what dose actually gives me the same exposure I'm going to get in a dog or a human that are taking this drug with cancer. And so by giving multiple doses, we can actually do linear extrapolations to human exposures and or canine exposures to figure out what dose mimics that. And it turns out it's right around 40 mg per kg. We have that. I mean, I can show you that. It's not that interesting, but this gives you the same exposure in the blood and organs that you would see in a human, or in a human. For a dog, it's about the same, being treated with, I think, whatever dose we went forward with in the phase 1 trial, which I can't remember, but I think it's 10 mg per kg. But anyway, you can see that here are the simulations, and it's important to note that this line could exist without these points. It is not a fit. It is a simulation based on that model. Okay, so it's a true simulation. We can generate lots of these based on however we want to change things. But we can simulate blood, we can simulate liver at multiple doses, we can simulate kidney at multiple doses, and we can simulate gut at multiple doses. So we've put together a model that can actually predict drug levels across doses in tissues in a mouse. Okay? Well, that's all fine and dandy. The cooler part is that we can scale this to humans by changing all those parameters, the blood flow parameters, the metabolism parameters, the organ volume parameters, and all those things. And he actually, Keegan simulated 5 human trials that have used hydroxychloroquine in combination with temsirolimus, yeah, that one, Verenostat, temozolomide in glioblastoma patients, bortezomib, and then temozolomide in some melanoma patients. And you can see that here's the simulation and here's the actual level, steady state level in patients at each dose level. So not only can we simulate these levels in a mouse, but we can scale this up to a human, not changing anything else, and actually predict the levels that you see in patients. Okay? It even gets better because he actually can then run a Monte Carlo simulation and actually variabilize the model across all the parameters across their normal distribution. And we can actually get mean levels. Our distributions are a little bit bigger. You can see that we actually almost can simulate not only the average levels, but also the distribution and variability that you would see in a human population. Okay? Why is that important? Well, we've shown in the past with docetaxel that we can take these Monte Carlo simulations and go back and probe these for where the variability comes from, and very often it matches what you see in the human population. So some of those genetics, some of that variability that that cause PK variability, you can actually pull out from these simulations. Not always, but we were able to make it work with docetaxel, so you can actually utilize these as kind of in silico probes to figure out where variability comes from. So you have a little in silico army of patients that you can muck around with and do things with. Okay, so we have a very nice model now to simulate hydroxychloroquine in the blood and other organs. Okay, we also know from some of our breast cancer models that we get differential uptake over time of hydroxychloroquine in these tumor cells. And so this model here, this data here was actually just published in JPET last month. This stuff is currently ongoing, all right? So I'm showing you this is all more or less brand new data. And so what we're doing now is we're looking at the pH, and we're trying to modify the pH of these cells by using some proton pump inhibitors, by using some different buffering systems to look at uptake, so we can now start adding a tumor compartment and start trying to predict tumor uptake based on these pH differences that we've put in each cell. Okay? So to try to capture that dose exposure variability, these simulation models give you the opportunity to generate things that you can start playing around with in silico. And then you can try to see what happens if you then can alter or perturb the system in a cell model or even in a tumor model that we put in a mouse, either with any of these cell lines, which we know have varying sensitivities to autophagy. All right. So now we have tools where we can start figuring out how dose and exposure are related based on this large PK model that incorporates not just blood, but all the other organs and this other subcellular distribution of this drug. Okay? So what we're going to be looking at is effect of alterations in cytosolic or lysosomal pH, effect of HCQ on sequestration of other lysometropic agents such as doxorubicin, which our first speaker touched on today. Dox is a weak base. It likes to go in the lysosome. If we start making the lysosome more alkaline because we're adding HCQ, dox is going to go out of there. Okay? So you might actually be increasing or blocking that sequestration. So we may not be, the autophagy interaction with dox may be nothing. It may be the fact that we're just kicking it out of the lysosome so it can go muck around with the cell. Fine with me. I just want to kill tumor cells. I don't care how they die. So I mean, that's true, right? A dead tumor cell is a good tumor cell. Okay? Effective HCQ sequestration is important, and now we can start looking at the relationships between blood and tumor and figure out what in the tumor, and if we have probes to measure pH, and we can use pimenidazole and think about hypoxia, you can start predicting what the pH is if you can get enough drug in there based on these differences to actually affect autophagy. Then we can get good relationships between the blood and the target. Okay? So those are the kinds of approaches that we're trying to take to do that. All right, so in summary of this kind of first drug exposure part, canine cell lines can be killed by hydroxychloroquine. That's why we care about it. We're also, and this gets into the next part of the talk, we're actually trying to figure out gene expression signatures that tell us that those cell lines are sensitive. So if we can actually look at signatures in the cell lines that say, hey, we like to be killed by autophagy, and then I can say thank you, and then we can kill them. We know that we can get HCQ and doxorubicin, which has been talked about as a standard of care for osteosarcoma. We know we can get those two drugs in dogs safely because we've done it with lymphoma. So if we work out which osteo tumors can be killed by this combination, we can jump right to a trial because we've already done the phase 1. We know that we can give the drug safely. Both hydroxychloroquine and chloroquine are drugs that are easily available. Right? You can get them, so we can use them in the veterinary space. Why? Because they're off patent. HCQ is a little bit expensive, but chloroquine's pretty dirt cheap. So you can get these drugs to actually do these trials, and if they're effective, you got something that you can run with. And these PBPK models allow us to simulate dose and schedule, all the things we've talked about, to optimize how much we get in the cell. All right? So we can start playing around in silico with our in silico army of virtual dogs or humans to start playing around and doing that. And we've done that a lot with doxorubicin. We did it in the ABC B1 knockouts, which we published years ago. So done a fair amount of this, so we can really now we've got a model that we can actually mathematically change and go, hey, where's the drug go? Oh, look. I mean, it's like a video game for graduate students, right? A lot of fun. You can generate stuff and actually do experiments on the computer, right? So we're in a good spot with this drug now to start doing those types of things to optimize what we're trying to do to optimize our dose and our exposure. If you look at this with regards to this whole autophagy inhibition paradigm, we got our PBPK model of HCQ. We're thinking about lysosomal uptake, how that affects the pH of the lysosome and how it affects other drugs like doxorubicin. Actually, I didn't include this here, but it's in the paper. HCQ is metabolized to diethyl hydroxychloroquine, which is an active metabolite. So we can actually track that as well. Why? If it's sticking in the lysosome, it's going to muck up things just like HCQ. We can do population modeling, and we can start simulating drug combinations. You know, with weak bases, do they stay there? How much more do you get in the cell now? How are you changing the intracellular distribution of doxorubicin from the lysosome to the cytosol, to potentially the nucleus? And from the PD side, we've already measured tumor cell response to HCQ. We're identifying this autophagy dependence. We have one of my grad students now, Kristen Jackson, is working on some CRISPR knockouts in collaboration with Andy Thorburn's lab to really definitively show that some of these cells are autophagy dependent, which gives us then the data to start looking at these genomic or gene expression indicators to model this. We know tumor response to autophagy inhibition and mechanisms of resistance, which has come out of some of the stuff that's come out of Andy's lab that we're playing around with as well. We can think about optimal drug combinations based on what we're doing over here to the tumor to get the response. And then certainly there's the effect on the primary tumor versus metastasis that we can start thinking about. So when I'm thinking about autophagy inhibition, it fits into this model in terms of drug exposure response. And taking all that stuff into account to thinking about at least a drug we know we can use. Can we model it and use it in a way to get to this endpoint, which is knocking down autophagy and killing these tumor cells? Okay. All right. So when we start thinking about predicting drug response and doing PD, where does that data usually come from? And where do you go if you want to know if something's sensitive? Do you start with tumors right away? No, we always start with cell lines, right? You go to the TCGA, you go to the GDSC, you can go to the NCI 60, and you can start looking at what cells are sensitive, okay? And I think when you start looking at cell lines, it's important to think about this component as well, okay? And this is something that we've been working on for a while. It's not, we haven't broadly used it, but we do now have all the calculations where if you think about these drugs, and these drugs are here because these are the ones that we're working at modeling in the next part of this talk. These are all cytotoxics. I actually went through, and this is work that I actually did, not the graduate students, so they can't take credit for this. So this is the one slide that Dan actually did, okay? I went and I found the dose of these drugs that are normally given to people, okay? And this is human exposure, but you could do the same thing in dogs, you could extrapolate it. And then I went and looked up all the pharmacokinetic studies and calculated out the normal exposure in the blood. So this part right here. What's the exposure in the blood given this dose of these drugs? Okay. And I calculated them all in the same units, which is micromolar time hour, right? Because AUC is area under the curve. It's concentration of the blood times time. And so you actually get something that looks like something that you could actually look at in culture. And the reason I did this was I went, okay, if I look, and here's, okay, I'm done. That's a preview, kind of the next Star Wars movie. All right, if you look, so this is what a drug looks like if you give it to a critter or to a human. It comes down over time, and you can calculate an AUC. When we treat cells in culture, though, and this is just a simulation of 48 hours of exposure, which is pretty standard, you hit them at a given concentration. So here's maybe 100 nanomolar, here's 2.5 nanomolar, and here, or I'm sorry, 100 nanomolar, 250 nanomolar, and 500 nanomolar. You can actually calculate out their exposure by multiplying it by time, and you get a micromolar times hour, all right? Now it's not perfect because it's a square, and this is not a square. That's a octalotogram, okay? But you can actually at least now start comparing the exposure. So this one here, which turns out to be about 17.5 micromolar times hours, would be less than 500 nanomolar for 48 hours, but actually more than what you would see at 250 nanomolar. And the reason I'm talking about this is now you can start thinking about at least comparing what happens in vivo to what happens in vitro. So are these exposures crazy? Okay. Now you can also start changing in culture medium over time, but that's a tough assay. Okay, that's tough to do, is to constantly change it. But the point here is that you can actually get some time and concentration measures to start doing comparisons. Are those realistic? Well, yeah, we've known for a long time you can either you can treat cells for 2 hours with chemotherapy, increase the concentration, and you get a curve that goes like that. Or you can treat at a given concentration and just increase the time, and you get a curve that goes like that. So concentration and time for most drugs is more important than peak or trough, okay? And so this is not a crazy measure, all right? And it's a better way to start thinking about this dose and exposure in tissue culture than just saying, eh, okay? And so the cool thing is when you do this, and this is for, I just did the drugs that all fit in the same GI50. If you look at the growth inhibition for 50% of the cells, and this is across the GDSC, if you take bortezomib, what it turns out is that none of them, only 2 of the cell lines are actually above it. So almost all of these cells show GI50s lower than the AUC of exposure for bortezomib. So almost all of them are sensitive. So if you said, I'm going to draw the sensitive and resistant down here, that's not really realistic, right? So now you can start differentiating sensitive and resistant cell lines based on actual exposures and not just based on 50%. Here, cisplatin, the same way. That's good because it's an effective chemotherapeutic agent. Then there's one, where is it? Dox is almost right in the middle, which is good. Bleomycin, almost all of these are resistant to it, and only a few are sensitive. All right? How many of you have ever heard of bleomycin? No, it's because it sucks and doesn't work. That's why. Okay? All right? Not very many cells are sensitive to it. Okay? And so when you actually look at it, and a lot of these are right in the middle, which made me very happy. And if you go through a lot of the other ones that happen. So what that tells you is that the chemotherapy agents that we actually use can actually kill tumor cells. Okay? That should make you happy. All right? We're not just making people or dogs sick with them, but they actually come in at concentrations where you can kill them when you look at it. And when you actually take this exposure into mind, you can actually still get numbers and get sensitive and resistant cell lines that actually make sense, okay? Okay, why do we care about this? Well, because one of the things that we're doing when we start thinking about drug exposure and cell response is trying to figure out if we can find a molecular signature that we can use to actually predict what's going to be sensitive and what's going to be resistant. Why? Because if you get a tumor biopsy, you're not really going to be able to get cells. People have tried this for years to put into culture and then treat with all these drugs and then go use this. Why? Because the patient's already probably dead because they've progressed by then. Or number 2, it's not that easy to get a tumor in culture to grow long term. How many of you have ever tried to get cells to grow in culture? Yeah, it's not that easy. Get a lot of fibroblasts, okay? I mean, establishing cell lines, if you're going to do that for a living, short term, maybe, all right? But anyway, these types of screens people have been trying for 30 or 40 years. And so these genetic signatures are probably a better way to do it, okay? And if you go back and look at the data, and this is some data from what they call the DREAM paper that Jim Costello came out with in 2014. You'll be happy to know that it didn't include the Polity data that actually was, which I've actually used that story as a reason the NIH should fund me because we haven't made up anything fraudulently. And so that one I'm quite well aware of. And because of that, actually, Jim put together this study where he had people submit their predictive algorithms to him, and there was 44 of them for breast cancer, and they independently looked at all of these with them doing the modeling, them doing the data analysis, and just using their modeling algorithm. And so this was a really nice thing that came out of those, that data that came out of Duke, was that people said, hey, you know, we need to have this independently validated in other people's hands to make sure it's robust. When Jim did that, the thing that came out was when you looked at these drug sensitivity prediction modeling algorithms, the big indicators that came out as important, whether using elastic net or these kind of multitask type Bayesian models, is gene expression, okay? And mostly for cytotoxic agents. So the top performing models were gene expression models. There were some of these reverse phase protein arrays actually worked pretty well. But in a lot of these models, the old expression array was as good as, or if not better than methylation or RNA-seq or copy number or exome sequencing for a lot of these drugs. And so using gene expression and nonlinear modeling seemed to be the best way to do that. Okay, that's good, all right? Because data later, and this came out from Iorio paper in Cell, which was, if you read it, will blow you away because there's tons of data and it makes your head hurt. They did 1,001 cancer cell lines with 265 drugs. And the thing they showed right down here when you look at gene expression is that for a lot of these drugs, gene expression also gave their best prediction of modeling, okay? And especially for cytotoxic agents, methotrexate right there. trametinib is not a cytotoxic agent, so I should have just whited this one out because it doesn't fit in my paradigm. No. So methotrexate, so gene expression seems to be a good, one of the best ways to capture cellular data to predict a drug response. And so that was good because that's what we wanted to use. Okay? And the general thought here and the general kind of where everybody is that for tumor cell lines to targeted agents, it's best to have whole exome or RNA-seq data. Why? Because a lot of targeted agents are based on addiction and pathway activation that a lot of time comes up with regards to mutations. So mutations in BRAF, mutations in NRAS, mutations in KRAS. And so, you get vemurafenib if you have a BRAF melanoma. Why? Because that drug was developed for that. But for cytotoxic agents, and that's what the space that we were really looking at, is best predicted by models that primarily use gene expression. Okay? So we decided to start using gene expression models to start thinking about predicting response of canine tumors to drugs. Okay? And we had some other data that suggested we could do this, and this comes from Josh Mannheimer, who's a PhD student in my lab. We just took all the genes and did a bunch of principal components regressions and partial least squares regressions. And what you can see here is when you take a bunch of cells, the correlations aren't that good. But there's 300, 400, 500 cell lines in some of these. Well, no, that's not that many. They're here, 142. So I lied, 142, 148. You do get significant predictive power when you use all genes. And all this tells you is that within that gene expression signature, there is some prediction of drug response. Okay? All right, well, that's good. Okay? And this is just using really simple things like principal components regression and principal least squares with no kind of reduction in the genes that we're using. We just used all genes. Okay. So when we started doing this, I can tell you it was not my idea, but Dan Theodorescu had just come to the University of Colorado as the director of our cancer center. And he knew that I was kind of the most mathy of the farm guys around, except for Jim Costello, who actually happens to be at CU, but he was busy doing other stuff. So Dan roped me into thinking about using this Coxon method that he had developed and published in 2007 to start thinking about predicting drug response in canine osteosarcoma or canine tumors. He originally wanted to do transitional cell carcinoma, but I said that doesn't respond to anything, so we're not doing that. So we decided to go with osteo. And so this is kind of what they do, and this is a better I made my own slide here. And really, when we started this, and this is about 10 years ago now, he wanted us to say, hey, can we use data from the human NCI-60 and predict response in here our training set, where is it? Oh, our independent validation set here being a dog tumor line. All right. So can we predict the response of canine tumor cells using human gene expression data? Why is that important? Because the NCI-60 has screened over 10,000 drugs. Because the GDSC has data all over the place in human cell lines. Okay. How many canine cell lines do we have, and how many drug screens have we done in them? Not very many. Okay? We have 30 and we've done 5 drugs maybe. Okay? Does anybody have a bunch of data they've been hiding on us? No, I don't think so. So this gives us all this human data to start doing some comparative work with. And so basically what you do is you separate into sensitive and resistant. You figure out what the differentially expressed genes are between these. You do this kind of, they call it co-expression. It's really correlation of correlation to get genes in your test set pulled out of your differentially expressed genes. The reason you really have to do this is because when we first started doing this modeling, we were using linear discriminant modeling. And so the more features we had, it took a really, really long time to do the modeling when it started adding one gene at a time. So this is one way to do feature selection. You pull out those gene probes after you do this co-expression, and that's where it gets its name Coxon. And then you just start looking at whether you can predict drug response using these genes. Okay? And voila, you get a prediction that either tells you that you can or you can't. Okay? So we said, let's try this. Let's start trying to predict response in canine tumor cell lines with human data. And the data that we used, it's not just tumor cell lines. We actually, we wanted to actually get to tumor response. Why? Because I don't really care if I can kill tumor cells. I want to kill tumors in an animal. So we actually then wanted to get to the animal, so we needed tumor data sets as well as tumor cell line data sets. And luckily we had those. So we had the NCI-60 data, which you can go on your computer right now if you have internet access and start playing around with how different cells respond. I wouldn't do that because my talk's too interesting, but you could. We had 10 human cell lines from the GDSC that were osteo. We had what we called our FACC 29, so we had 29 cell lines in our canine panel. This has since gone up to about 36. And of those, 10 of them were osteo that we could bring out. And then we had some osteosarcoma tumor data that we had response data with, what drugs they were given. And we had those divided into two groups, one of 16 that Don Duvall had used to do some predictive stuff, and then another 33 that we did independently. Okay, so we had 49 tumors and then all these cell lines. So we started playing around with some gene expression modeling. The first thing I'll say is for these drugs, vinblastine, paclitaxel, CCNU, DOX, and cis and carboplatin, we had that data because these are broadly used in vet med for the most part, and we wanted to, well, Taxol's not, but I like it, so we threw it in there. We wanted to see if we could take the human cell lines and predict. And here's the p-values binomial, means it's a coin flip, so you call it sensitive or resistant. And the Pearson and Spearman correlations, these are based on kind of how big the bar is. So this means it's resistant, this means it's sensitive. The length of the bar tells you how sensitive and how resistant it is. The reality is if we just looked at the sensitive and resistant call for 1, 2, 3, 4, 5 of these 6 drugs, we could predict whether they were sensitive or resistant based on the human cell line. Okay? And cisplatin was the outlier, and we don't care about that anyway because it fries kidneys. So yes, the answer is we could. We could predict just straight up cell line sensitivity in canine cell lines based on human cell line gene expression. Okay, that's good, all right. So I'm not going to show all this data. It's all published in the BMC bioinformatics paper that Jared Fowles published from my lab a couple years ago. But we also started trying to look at tumor response prediction, and here you have the log rank or Cox hazard ratio value. And it turns out for doxorubicin, if we found our differentially expressed genes based on sensitive and resistant NCI-60 data, we co-expressed with our canine osteosarcomas to osteosarcomaize the data. And then we would train on that as well. We could predict the response in these other 33 tumors quite well with p-values that are certainly in the you can actually do this range. Okay? And so we could predict response of these animals based on genes that were picked based on drug sensitivity, and that's the key. The genes came from here, drug sensitivity, from there. Okay? And if we tuned them enough and played around with them enough, we could actually get predictive models retrospectively. Okay? Carbo was a different story. The answer is no. Carbo doesn't like the human data, but if we took and we got dog genes from their sensitive and resistant, we could get a predictive binomial value. And the reason we wanted carbo is because carbo is the other choice you have for osteosarcoma. You got carbo and dox. All right? So the modeling wasn't as clean with carbo, but we could predict sensitive and resistant using dog genes. So we used a kind of a dog-on-dog model versus a human-on-dog model, okay? And so here, the human is our preclinical species. Here we had to go back and use the dog, okay? So we did have a model for dox and for carbo, and the kicker, there's two things. One, in this original analysis of 16 osteosarcoma tumors that Dawn did, she pulled out a predictive gene set that would predict whether the dogs would progress early or late. None of our genes none of the genes that we had for our models matched hers. That's important because that showed that it was all based on the drug sensitivity data that we used from the beginning. Because these are really good indicators of outcome if you go back and just look at whether they're going to progress early or progress late within certain sets. Ours was based on drug sensitivity. And so these genes didn't match. So that made us really happy. So those genes didn't match. And if we put these together and we took from that cause 33 and we looked at the ones that said they would respond to the drug or not respond to the drug, we got some very significant results retrospectively. When we looked at the dogs, and again, these weren't involved, these were the 33 dogs that weren't involved in the initial modeling, we could predict who was going to respond and who wasn't if our coxswain matched or the coxswain was a mismatch. So this means they got a drug that we would predict they were insensitive to. This says we would predict they would get a drug they were sensitive to. And when you looked at then a multivariate analysis, body weight and proximal humeral tumor have been shown to be indicative of response in osteosarcoma. The coxswain model by far had a much better hazard ratio. It was 0.31 if they were coxswain matched. So that was pretty significant with regards to what they were going to do a lot better. All right. So I said, all right, this is all cool, but this is all retrospective. So we wanted to do a prospective trial. And so we wrote one up, and Morris Animal Foundation funded it. The basic way this works is dogs are diagnosed with osteosarcoma. You amputate them, and one of my favorite Steve Withrowisms are dogs are born with 3 legs and a spare. And so if you're in Fort Collins, there's lots of, I've seen some three-legged dogs. So anybody that knows Steve knows that's Withrowism from way back. And we can do this in 2 to 4 days. We get the sample, we do path review of path samples to make sure that it's osteo, there's good viable tumor in there. We do sample prep. These actually go to the CU Genomics and Microarray Shared Resource, where they get analyzed, and usually the data is back to us within 5 days, and we can model it. By the time those dogs come in 10 days post-surgery for their first treatment, we already have a prediction. Okay? And we put them into 3 different treatment groups. If we predict that they're sensitive to doxorubicin and resistant to carbo, they get dox. If they're resistant to dox, sensitive to carbo, they get carbo. If they're sensitive to both, they get a combo. And if they're resistant to both, they get the combo. All right? So we stacked the mismatch against us by giving the most aggressive therapy to the dogs that we would say aren't going to respond to either. This is funded by the Morris Animal Foundation. We got some extra money from the Danny Foundation to help supplement it. And right now, we have 55 of 60 dogs are already enrolled and ongoing. I think there's 3 planned for the next 2 weeks. So we are almost to our accrual. The other thing is the follow-up on these is they're given chest films every 2 months. And so we're looking at time to progression. We're not looking at overall survival. We're looking at the formation of lung mets as our endpoint. Okay, so we are going to have that follow-up data with regards to progression. We would predict, here's a historical control from Laura Selmick's paper. Here's what we predict the match should be versus the mismatch. So if we can actually predict what they're going to do, now you're talking about a median survival time, percent disease-free survival time out to 500 days. Speakers before were talking about 100 days, right? Which is basically what you see here. This data is a little bit better than that. But this is a significant improvement in outcome for a lot of these dogs, with a fair percentage of them surviving out to close to 3 years. All right, so here's what it actually looks like. Here's the patient predictions. And again, they're being reviewed. We're taking viable tumor fractions. RNA is being isolated from each of these 2 arrays. We're doing the coxswain algorithm. And here's the prediction. If it's red, they're resistant. If they're yellow, we call them resistant. And again, the reason is because the coxswain algorithm actually gives us a probability. So 0.5 is a coin flip. So if I said, oh, it's 0.51, now it's sensitive. That gets back to the discussion we had earlier. 66%, 2 or 3, that's not good. So that's our minimum. We make sure that we predict them to be sensitive at 2 out of 3 times we flip that coin, it comes up heads. To make it green, everything else is going to go into this resistant bin. Currently, we have 19 dogs that are mismatches, 33 that are matches. It fits more or less within our predictive model when we did our power tests to begin with, so it looks like the trial's accruing in a way that's going to give us some meaningful data to predict what's going to happen. We have some data. I refuse to look at it. I won't open it. I even thought about it to bring you guys to show you some preliminary data, but Doug talked me down and said he'd hit me if I did, so I said no. And he had a stick, so I was like, okay, I won't do it. But anyway, we're getting close to getting this done. Okay. That's really based on some old school cell modeling. And when we start thinking about drug exposure and response, There's a lot of better ways to do that now, and it's based on computing power, it's based on the bioinformatics, how fast things are moving. There's now RNA-seq data, blah. I mean, the original paper that we were basing this off of was 2007. That's 11 years, all right? How many of you remember science 11 years ago? Is it different? Yeah. We didn't have self-driving cars back then. I mean, heck, we barely had, so 11 years is a long time. So I wanted to show you a lot of the stuff that we're doing now with modeling drug response, because it's gotten a lot more sophisticated. And we're, for the most part, our focus now is on feature selection to figure out what genes we should be focusing on for drug response. And the earlier talk actually gave me, we have sex differences, right? You have all these differences, and people were talking about the fact that a cell that comes from the luminal or the basal looks like the luminal or the basal. And the reality is, if you take tumor cells and you do gene profiling for them and you do unsupervised clustering, how do they separate? By histotype, okay? And so one of the biggest predictors of drug response is histotype. And the pathologists love to hear that, because then they go, yay, I have a job, okay? The molecular guys aren't going to run me over. But we're trying to separate that, to try to separate the wheat from the chaff and try to get away from that histotype designation, to really get at the genes that are predicting drug response, to get a little bit deeper with regards to that. Not just across histotype prediction, but within histotype prediction. And so we have a lot of focus on feature selection, and we have an RO3 and now to do a lot of kind of modeling, pathway analysis, and a lot of other informatics approaches to feature selection. The way we're estimating parameters now, we are using neural nets. We're using support vector, linear, nonlinear support vectors, a lot of different modeling algorithms instead of the type of linear modeling that we've historically done. So, and again, it's a lot because these algorithms are out there and the computer-based processes. And I have the right collaborators now that are chemical engineers that know how to do this stuff. To predict these IC50s. Josh Mannheimer, who's a PhD student in my lab's prepping this manuscript right now. He just sent me a draft, which he's going to be mad at me because I haven't read completely. But the gist of this is, and I was going to show you this data to kind of emphasize this, is that when he starts picking out genes, whether they be differentially expressed from resistant or sensitive, or just randomly pick any genes, he actually, for a lot of these drugs, he can predict very well their sensitivity just with random genes. And the reason is, right here, is that when you look at a correlation between drug response, and again, this is for a lot of cell lines, this is what he calls an entropy score. He's a big fan of entropy, almost in a weird way. As you get to zero, what happens is you go this way, you get more randomness. And what this randomness is looking at is whether it can put things, it's Euclidean distance associated with how they separate in an unsupervised cluster, but it also tells you how random your data is. And what he really shows here is that if you take just random genes, if you get up to 1,000, these algorithms are really good at telling what the histotype is. And so you still get pretty good predictions. And this goes down linearly almost with the number of features. And once you get down to 10, it's not really good at telling what histotype it is. And, but then the differentially expressed genes actually now can still make a prediction, but these random ones start to fall off. And so this really shows that what we're doing is we're just able to do really fancy molecular pathology, and we could get a pathologist to do that, and they go breast. And so we're really working to deconvolute some of this histotype so we can start optimizing some of these models. And again, these are, we're working with 13 or 14 drugs, multiple cell lines. He has a ton of data that we've worked through with all these types of different modeling paradigms to really get a baseline of how to handle this data to make good predictions for these cytotoxic agents. And the point is that we need to start deconvoluting the histotype from these drug response genes, or we don't. If we don't, and histotype is still the best identifier, that might be okay for a lot of these drugs, but that's good to know, right? I just need to know if that's breast cancer, and I'll know it's going to respond or not. Okay. or maybe within breast cancer, which ones respond. So we may have to separate the histotype and start doing that. But anyway, we're really starting to look at these genes in a lot different ways. All right, I went over a ton of stuff really fast, and you're probably saying, boy, I don't even know what that guy talked about. If you remember anything, drug and exposure is PK, drug and response is PD. And you need to know how much drug is at a target to figure out what your response is going to be, and you need to know how that target is going to respond at that concentration to know what your response is going to be. So it's dose, exposure, response, with exposure at your target. Intrinsic sensitivity of tumor cells seems to make a difference, and how the drug gets there, what the drug is, and how it relates to that sensitivity or resistance value is critical. Once you know those, drug responses start to make sense. Okay? Again, I did very little of this except that one table, which is by far the most important piece of information in the whole talk. Jared Fowles did all the Coxon modeling. I talked him into doing it. When he finished his PhD 6.5 years later, he said that was not a good idea. We should have. He's currently at University of Washington University in St. Louis, doing a bioinformatics postdoc. Really smart guy. Keegan Collins here. Grad students are dumb. I'm like, hey, sit on that hippo, and I'll take a picture. When we were at the San Diego Zoo, and he did. And I'm like, okay. And then he did all the HCQ modeling. Josh is as dumb. I had him sit on a gorilla and take his picture. He's doing all the cell-based model. Kristen Jackson is a PhD student doing a lot of the autophagy knockdown work. Kristen Brown was a rotating student, very talented coder actually, who taught all my people how to use R years ago, and so we'll give her credit for a lot of the Coxon modeling. Christine and Katie are undergraduates who, Christine worked for 4 years in my lab as an undergrad. Katie's worked for 2. She's off in Spain doing a fellowship this summer, which is a good idea. All my collaborators, Dr. Duvall, most of you know my wife, so she tells me what to do all the time. Don's done a lot of the cell work and cell line validation. Andy Thorburn at CU Denver. We've had a R01 together for 10 years now on autophagy. Ann Hess is a statistician, Ashok's bioengineer, mechanical engineer who's doing a lot of the pathwork modeling. Dan Regan's a pathologist. And Doug Pham, most of you guys know him, medical oncologist, who always tells me that's smarter, that's dumb with regards to how we treat dogs with cancer. EJ, another pathologist, and everybody else. Funding, NIH, Morris Animal Foundation, the Animal Cancer Center itself, and the Shipley University Chair. You probably know a lot of these people. Where's Steve? Yeah, Steve's there. Steve Withrow's there. There's Don. The whole Animal Cancer Center allows me to do what I do, thinking about animal and human cancers and mouse cancers and everything as one spectrum. And that gets to the question we had earlier when somebody was asking about how do we get money to do veterinary cancer studies. My advice would be don't separate them. Dogs are a surrogate for the human disease. Let's look at the canine and the mouse disease as a continuum with the human. And I think if you do that, then you don't need as many big data sets. I know it's easier said than done, but I think if you can do that, it makes things potentially be used that way. And Morris always tells me I have to put this slide since they paid for stuff. And with that, I will gladly take any questions.
Thanks, Dan. What questions do we have for Dan?
Dr. Wood.
Thanks, that was really interesting, and it's not something I think about that much. So it's an interest to get animals. But when you're doing your cell line work, have you ever tried or thought about getting the pH down, low glucose, those kinds of things to get that the sort of microenvironment more like a tumor first before low oxygen stuff before you do this?
Yeah, so that's a great question, and we go round and round. Doug tells me all the time you need to do everything in low serum, and I'm like, well, let's find the baseline first, and then we can start stressing them. We are doing a lot of work. Dan Regan, one of his projects is looking at 3-dimensional and with fibroblasts, looking at breast They form acini. They actually look like little, looking at how they respond to autophagy inhibition and these things, it's hard to separate them. That's a little bit different question, but I think you're absolutely right, is that stressing them. I spent my whole graduate career doing hypoxic studies with tumor cells with mitomycin C and looking at how much greater you could kill them. But I think one of the things that's interesting is that a lot of the data that we get, the big data we get from the NCI-60 and the GDSC, is done in these normal conditions, which for a tumor cell is 10% serum, high glucose, and 95% air, 5%, which is how tumors grow, right? I mean, it's very physiologic, which means that's the concentration a physiologist uses. So trying to work in those specialized conditions, we have a problem reflecting back on a lot of the big data that we're trying to model. But I agree with you completely that looking under stress conditions might give you a much better idea, especially in the pre-metastatic niche or in an anoicus situation. I think you really have to start looking at what these tumor cells are undergoing, and they're not, growing on plastic in these high oxygen concentrations. So yes, we think about it. We do it less than we should because it makes things harder. So, but I agree completely, and those perturbed systems are actually critical. Come on, somebody's got a question. Yeah.
You mentioned that the microarray is better than RNA-seq for like the non-targeted therapies. Is there an advantage other than cost, or?
So the question is gene arrays versus RNA-seq. I would never say better. The problem is right now is that we have a lot of array data. I think RNA-seq has a lot of advantages, like for some things you'll get close to zero. And in gene array data, you always have this background fluorescence, and your normalization isn't this type of digital count that you get in RNA-seq data. And so I think my argument would be that gene expression data seems to hold a lot of the keys that predict drug response, more so than mutational status for cytotoxic agents. So I don't know if it's RNA-seq versus gene array data as much as it is gene expression, which is manifested in all the other things that cause genes to be turned on and off, as opposed to maybe activating mutations that you would also find in RNA-seq based on sequence data. Does that make sense?
Yeah, but the RNA-seq would also have like quantitative, right?
Yeah, no, but the GDSC, I have 1,000 cell lines with gene array data that I can normalize all using these, RNA combat or other type algorithms, so I can use them all together, whereas RNA-seq data, there's not as much of it right now. So it's kind of a numbers game now. I can tell you that in some of the bladder cancer projects that we're working on, we do have RNA-seq data along with array data, and the actual expression of genes correlates very well, except for this fact that some of them drop out at zero. So I think the RNA-seq data and the gene array data are very similar. We're trying to figure out a way how we can use both of those and use them together almost interchangeably. But that gets to normalization, and you don't want to flatten the data too much, so that gets a little bit tough just in the data handling type standpoint. Yeah.
I have also a question also relating to the cell cultures. When you draw the square curve underneath, is there not something to consider about the cell interactions, the media, the metabolites coming in, maybe some changes to the drug over time in the media?
Yeah, so the question is when I'm calculating the AUCs, the time and the decay of the drug potentially. So that's a great question. And most of those drugs are pretty stable in culture. The ones that aren't are cisplatin and carboplatin. And I've actually modeled their decay, because people have measured that by first order. So they actually don't fit a square in culture, they're a triangle, because they get a first order decay. So when I know that there's an instability, all the AUCs I've calculated have been done using that type of decay, or if they're metabolized in culture. Most of those drugs aren't metabolized by tumor cells per se, or at least in any appreciable way. But that's a great question. And cisplatin's the example where you get this kind of normal decay of it as the dichlorodiaminoplatinum reacts with things. That one, people have done decay kinetics with, and so I just took advantage of that and did a first order decay of it. Great question. Yeah.
I have a couple. One is, the idea that RNA is a better predictor than DNA, in a lot of ways makes a lot of sense, because it allows convergent changes to hit a couple of pathways. But if you follow that argument, then shouldn't we be just doing metabolome, or as somebody this morning was showing proteomes, or other way around? But yeah, wouldn't that be a better predictor than RNA? And are we just kind of missing the boat by focusing on easy nucleotide sequencing experiments?
So the answer is, shouldn't we be focused on proteomics and metabolomics as opposed to RNA? The answer is probably, but as someone who has dabbled a little bit in proteomics, that's way hard. And I do think that the fact that RNA and DNA is a four-letter alphabet, and the fact that you can high throughput sequence it makes it easy. The problem with the proteome, I remember looking at a talk on proteomic analysis, I think of H3 histone, which has 12 acetylation spots, and then of those, and when you acetylate it at certain spots, it acts differently. So all of a sudden, the number of H3 you need to look at isn't H3, it's 12 factorial, because each of those acetylation, and that's just one protein. So I think, one of the problems with the proteome is certainly secondary modifications and activation, and that may be captured in RNA, because a lot of those activation steps in proteins then activate pathways which are transcriptional. So the answer is, I think you're probably going to have very good predictors that involve both once we get a lot of good proteomic data, good metabolomic data, and could put it along with the RNA data. And we're certainly open to using all that type of data in the algorithms. And I think that's going to be really helpful once it's generated. The high throughput nature of RNA data, I think, is why it has been where we've been living with drug response so far. So.
And a follow-up question. I'm curious your opinions. To make our models more accurate, how would you weight the relative importance of greater sample size, getting the larger diversity of cell lines and model systems and that, collecting more data, we just talked about protein, and core improvements in our algorithms so that we actually just model it better and more accurate and have better mathematical structures? How do you think about which of those is most important in weighting efforts moving forward?
Yeah, so the question really was about more data, what type of data, and modeling algorithms. So what goes in versus how we handle it and what comes out. I think the answer is all. I think the beauty of modeling is it's so output driven. Mel Anderson, who taught me how to PBPK model, told me when a model doesn't work, it's the best kind, because then you can try to figure out why you're wrong. When it does work, you're still wrong and you don't know why. So I think the modeling process itself really teaches you a lot about data and data handling and what you can do. And overfitting, I think, with neural networks has been a big problem for us. And sometimes we'll step back and go, wait a minute, because you can overfit, and then your test set you can't do anything with because it's drawn donuts around stuff. And you're like, holy schmoly. And so some of the nonlinear and linear support vector type approaches have been better predictors than neural nets because of overfitting. And so I think that the modeling sometimes gets down to use the simplest one you can to describe the data and make the best prediction. In terms of the data, I think you just have to keep fitting it in. More is always going to be better, but then how you normalize it and how you make sure you're comparing apples and apples is the problem. And so you always have the quality issue as you get more and more data. But the more independent test sets that you can utilize and the more robust you can show your model is, clearly the better it's going to be. So I think robustness is really the kind of getting more data and testing it, bringing in, and I think your data showed that clearly today. Sometimes you think you have a great idea and you test it and it doesn't do any better, and simpler may be better. And so, I think it's just finding that sweet spot, which I think what you showed today is what you're trying to do, right? You find the sweet spot.
Dan?
Yes.
You were doing your talks in algorithms. Did you see any other drugs that you would think if we had better formulations that met, like taxanes, would work against osteoarthritis?
Yeah, so taxanes are an interesting one because we predict really well, but the osteos weren't really all that sensitive. So there's no signature that really came off as being something that we would use.
Wasn't some other drug that we had formulations?
No, I did that. I did a reverse. So what I did is I looked at the sensitive and resistant osteos, and then I went back to the NCI 60 and we call it NEXOC, or kind of opposite coxin, and I looked for gene signatures of response in the NCI 60 that matched what we had, and the drugs that showed up were all redox active compounds, which were really, really toxic and killed everything. So I was like, so there was nothing that really jumped out at me. We've tried to do that. That was actually written in the original grant, but there's nothing that's really been really testable for us up front.
Any other questions for Dr. Gustafson? That will have us thank Dan for coming.
Yeah,